Okay. So again, thank you all for being here. We'll go ahead and jump in and get started. See if I've got the right. So I mentioned that we had our Spanish language interpretation available. There is a globe at the bottom of your toolbar. You can click on that if you need Spanish language interpretation. We also have American Sign Language interpreters online. So you'll see Terry and you'll see Rachel. If you need their services, you can access them. And just some reminders for our interpreters. Speak slowly to allow the interpreters to correctly interpret your messages. And just as a reminder, the interpreters cannot interpret information from chat. So please try to refrain from putting messages in chat and wanting the interpreters to translate that information. And here are just some ground rules. Just a reminder that this meeting will be recorded. We do ask that you do not share any PHI or public health information verbally or through chat. And just so you know, information that's included in chat may be part of the record that is open to anyone who is requesting information. And email addresses can be considered PHI information too. So we'll have my contact information, myself and Aaron's contact information at the end. So if we need to connect afterwards, you can use and reach out to us that way. And as a reminder, you don't have to identify yourself when asking a question. You can rename yourself in Zoom. If you would like to remain anonymous, you do have the right to do that. And just for our meeting ground rules, just as just a reminder of our guiding principles in the charter. Just remember, listen and be open to what is said. Be non-judgmental, value the learning, and listen to get smarter. And we ask everyone to contribute to our task force goals. And when you're working in your work groups and the breakout sessions and in our larger group, be intentional with your discussion, with your discussions and your comments. So here is just kind of a snapshot of our agenda for today. We'll look at priority 2 from the CMS Health Equity Priorities. We're going to do a report out. These are going to be our final recommendations from the groups. And I'll discuss more of that to come, but this is just kind of a highlight of our agenda for today. So as we start, we'd like to do a land acknowledgement, and we would like to acknowledge that what is now Colorado includes the lands of the Ute, Arapaho, Cheyenne, Dene, Lakota, Apache, Puebloan nations, and many tribes, and that the sovereign tribal governments of the Ute Mountain, Ute, and the Southern Ute Indian tribes still reside in this state. These tribes are the original stewards of these natural areas, and we want to take a moment to honor and respect these original stewards of the environment and their relationship with the land. So today we're going to look at assess causes of disparities within the CMS programs and address inequities in policies and operations to close gaps. Now we're wrapping up our coverage of the CMS Health Equity Priorities. So today we are going to end things with priority 2, Again, this priority 2 is assess the causes of disparities within the CMS programs and address inequities in policies and operations to close gaps. So priority 2 really is talking about how CMS is committed to move beyond observation and into action, assessing their programs and their policies for unintended consequences and making concrete, actionable decisions about their policies, investment, and resource allocations. Their goals are to explicit measure the impact of our policies on health equity, to develop sustainable solutions that close gaps in health and healthcare access, quality, and outcomes, and to invest in solutions that address health disparities. Now, CMS programs support the health of millions of individuals. So this makes the agency a critical engine for opportunities to center health equity in the delivery of healthcare, rulemaking, and policy development related to benefit and payment design, data collection, quality improvement, and research. And I think as it shows on the slide, CMS provides health coverage to more than 160 million, and that's through Medicare, Medicaid, and the Children's Health Insurance Program. So that's why there's such a critical agency when we're talking about health equity, because that they provide coverage to more than the 160 million individuals. There are many of the CMS programs have health equity and disparity reduction as a guiding principle. And listed here on the slide are just some of the programs that have those guiding principles kind of at the forefront of their programs. Because of how these programs impact unique communities within the Medicare, Medicaid, and CHIP Plus programs, there are many opportunities to understand, test, and design ways to evaluate these programs for health equity impacts and to measure disparities. So these are just a few snapshot of programs within CMS that really are focusing on equity and quality and kind of really working with the disparities. In addition to addressing the aspects of payment and service delivery, CMS also monitors and provides oversight responsibility in reviewing standards, ways to strengthen healthcare organizations, advance equity as they provide care. So 2 of their oversight programs, their monitoring oversight programs, one is called Conditions for Coverage, or CFCs, and Conditions of Participation, so COPs. And so really what these do, they provide a lot of health and safety standards around improving quality and protecting the health and safety of beneficiaries. They help CMS identify and eliminate potential barriers that underserved communities and individuals may face. CMS programs uphold civil rights laws and protections which prohibit discrimination based on race, color, national origin, sex, age, and/or disability. And so with this, CMS also has the responsibility to embed equity solutions and policies that safeguard these rights for all those that they serve. In particular, the focus is on members of the underserved or disadvantaged communities. Listed here on the slide are some areas that are covered by the CFCs and the COPs. So as you can see on here, most of the areas covered, it looks like it covers from your hospitals, it has clinics, it has the therapies, and it has suppliers. So over here, with their monitoring oversight, it's giving guidelines on how they operate, making sure that quality is covered. And again, it's looking at the equity, the civil rights. So that's their whole purpose, is in monitoring oversight of these. So these are just some of the areas that are covered. So you can tell that, majority of coverage, CMS looks at all these areas. So we have the ASCs, we have rehab facilities. So they're looking and monitoring all of these areas and their programs to make sure everything is equity and quality is taken care of for those that are accessing these services. CMS has a critical role in making sure to increase access to healthcare coverage for the underserved populations, and expanding healthcare coverage through Medicaid, Medicare, and CHIP Plus and marketplaces is where we have seen how CMS is doing this. And we have seen that in Medicaid and the marketplace, we have seen an increase where we've been able to help millions of individuals who are in underserved areas access covered health care. And then CMS also has a responsibility to ensure that every individual served by the agency can get the care they needed at a provider with whom they can travel, whom will serve them, and who they're comfortable with. So again, we know that disparities in coverage persist among members of racial and ethnic communities and others affected by systemic inequalities. And so CMS is always looking to adapt their policies to continue to make coverage across all programs more affordable and available. And they want to understand what may be causing disparities in coverage, and then addressing those. So that's part of CMS's responsibility and of all their programs is, really looking at them and again, providing that oversight to making sure that everyone has access to these programs, and that there's no disparities within the programs. And if there are, they find ways to address and get those covered. Now, CMS looks at, when they're doing this and when they're reviewing all their programs and looking at it through health equity, and looking at the quality piece of it, they're looking at it through the whole person view. When they're investing, they're looking at targeted health interventions, and they're identifying areas for reducing inequities at the population levels, such as avoidable admissions, and setting targets for reducing those inequities and considering how to make investments in key populations with especially large disparities in health outcomes, including the maternal and the postpartum health, and individuals in the justice system, and those individuals with housing unstable. So they're really looking at those populations because those are some of those high populations they know where there's large disparities. So that's kind of where some of their focus is, on those areas. And so again, they're looking at the whole person. So they're looking at the physical, they're looking at the living, they're looking at environmental, the skills, the safety. So they're looking at the whole person when they're reviewing and assessing their programs within CMS. And so they also believe in accessing or really reaching out. Excuse me. I apologize. Let me get right back to where you were. So what I was really trying to say is CMS really is invested in hearing from stakeholders as they go through and assess their programs and with the quality piece. So they're really looking at the stakeholder involvement, and that goes from agencies as well as individuals that are obtaining these services. So they're committed to their stakeholder outreach, stakeholder input, because they really want, again, that whole person to be involved in the programs and how they're developed and how they're planned and the services that they provide. So they really wanted to make sure that they have the voice, not only of the individuals that are receiving the services, but those agencies that are actually facilitating and providing the services. So that's another key component with CMS in assessing their programs. They really are focusing on outreach and hearing from the stakeholders and the community. So you always will hear and get information out, and we try to share information out when we know that CMS is looking for comments on programs they're thinking about, on programs that are available. You know, they want to know, is it working? What's not working? Are there disparities that we're not seeing? Because they want to make sure that they're not just making programs, but they want to make sure that the programs work for the individuals that they are sharing. So that is all I had for the priority 2. Did anyone have any questions? And I see there's comments out here. I'm just going to go through and just see. Let me fix the language interpreter. It seemed like it's. Did I?
Hey Dan, this is Aaron.
Okay, Aaron. Did I change it wrong or did I?
Let me see.
I don't know if I fixed. I tried to switch it back, and I don't know if I did.
Well, as you work on that, I was just gonna give an update on priority area 2 that you just reported on. Thank you so much for the information. You know, part of the emphasis on our health equity plan is to focus on CMS priority area 2 to really assess those specific disparity areas. And so the conversation that we're having with our RAIs is for them to actually look at the differences between statistical significant outliers that actually meet the fidelity of a disparity versus small gaps between populations. And so this next calendar year, we have an opportunity to really look at the data, and each of the RAIs will be providing their first versions of their health equity plans to us by early 2024. So I definitely look forward to coming back to this group to share out what the data looks like and then how we can really transform our internal health equity dashboard. We are trying to make sure that we take our internal dashboard, as you know, Dana, and make it a public-facing dashboard. That most likely won't be available until about January of 2025. But yeah, you're absolutely spot on what you just shared. So thank you.
Thank you. And if anyone is still having issues with the language interpretation, just let me know if I need to switch things back or change it. Okay, I think we might be okay. So here is just kind of a timeline. We may touch on this more in a little bit, but just to give you an idea. So today, we're going to hear from each of the work groups on their top recommendations to the department. So you'll have some time in the breakout rooms to work on kind of finalizing your recommendations that you want to put forth towards the department. We will come back together January and February. I'm still trying to get a date together for that, but we'll come back in early 2024 and we will vote on which recommendations will be forwarded to the department. We'll kind of recap again what we're hearing today, and we'll vote early 2024. And then sometime in the spring or summer 2024, we'll come back and provide an update on the recommendations that you've forwarded to the department, and we'll look at the kind of status and where they are and what where we are with that. So that's just kind of a timeline. Stay tuned for more specifics and more dates and more details, but just want to give you a kind of a high level idea of where we are. So we're getting ready to go into our breakout rooms. And this is just some action items for the work groups. We want you to pick your top 1 to 3 recommendations to report out to the larger group today. And I know some of the groups kind of have some of their recommendations kind of set. And if that's the case, that is great and that is fine. But as you're working through your recommendations, just kind of think about all of the priorities that we have covered in these last few months, the CMS health equity priorities, and just kind of see in relation to your recommendations, do you need to add something? Do you need to think about something, add a little detail related to maybe one of the priorities? And I just listed here on the slide each of the priorities. We talked about data. Today, we just talked about the assessing the CMS programs. And then we talked about building capacity of healthcare organizations and the workforce related to healthcare disparities. We talked about language access. And then we talked about increase all forms of accessibility to healthcare services. So as you're in your work groups, just kind of keep those in mind. But we really want you to focus and kind of nail down your 1 to 3 recommendations that you do want to move forward to the department. And I will share each group's the forms that you have been working on. I will share those in chat in just a moment. But for the breakout rooms, if you're in access to care, I'm going to have you stay in the main room. Behavioral health, you're going to go to room 1. The vaccines and COVID-19, you're going to go to room 2. And maternity is going to go to room 3, and prevention is going to go to room 4. So again, access to care will stay in the main room, and we'll have our ASL interpreters and our Spanish language provider will stay in the main room. So if you need those services, please stay in the main room. So again, behavioral health is in room 1. The vaccinations COVID-19 group is going to be in 2. Maternity will be in 3, and prevention in 4. And give me 1 second while I add all of the forms for each room to access. And Erin, can you help me and set the rooms up while I'm getting the forms? Do you have access, or do I need to?
I think if you make me a co-host, I can knock it out.
Okay. Okay, there you go. I'll stop sharing my screen. Now I'm going to find.
All right, Dana, just to confirm, the main room is access to care?
Yes.
Okay.
And give me 1 second. I'm gonna put the links. to all the groups in.
All right, the rooms are now available.
Okay, and I'm putting in the folders. This is behavioral health.
Did you say how long for each?
30 minutes.
Hello. I tried to access the folder through the link that you put in the chat, but it brings up a 404 error message.
Okay, thank you for letting me know that. Let me try some. Let me know if that one is better.
Perfect, thank you.
Okay, thank you.
I don't see a folder for prevention.
That one should be coming up in just 1 second.
Okay.
I believe is my next one. Okay, so all the forms should be out there, so everyone should be able to access each of the breakout forms.
And how can we join the breakout rooms?
You should see on the toolbar, it should give you a link to say breakout rooms.
Don't see it.
Do you see that? Do you see the 3 dots at the end maybe on yours? And you may have to click on it where it says breakout
Oh,
room.
yes. Yes, thank you.
Okay. And those of you that are here in the main room, this is access to care. So whenever you are ready, you all can get started. And I'll just kind of bop around to all the rooms just to make sure there's no questions.
Awesome. Thank you, Dana.
Hi, everyone. It's Renee.
Hi, Renee.
And I apologizing right now. My computer has crashed.
Oh.
So I'm supposed to have a new computer delivered today. So I don't have access to the form we filled out.
Oh, Renee, I can't hear you anymore.
Can you hear me now?
Yeah, yeah.
Okay. Sorry.
And I have the form pulled up. I just don't know if it's the latest version. I know we were emailing a couple weeks ago. So
I think Danae sent an email, then you have up, Lauren. Okay.
You froze for a second, Bong.
Hmm?
You froze for a second, Bong.
Ah, my internet is kind of shaky today too.
I do
Yeah.
have, I think our latest, I refound after we emailed a couple times. This one looks more formatted. So I'm going to go with this is the latest version of what we have. And I'm happy to share my screen if that's easy, or how do we want to do that? Okay, perfect.
Yes,
Give me one
please.
second. Does that look okay? And I'm sorry, my Zoom now splits my screens, and so I can't really see you guys in so anyways, let me know if I need to
Mhm.
zoom in, scroll, any of those
It's-
things.
Is there a number 4?
No. Oh, yes, there is now. So here's all of our recommendations.
Yeah,
Yep.
so that is the latest version. Great.
Okay.
Cool. So aren't we supposed to narrow down to 2? So if we have 4,
I think they said 1 to 3, right?
Yep,
Mhm.
1 to 3.
or we have a lot of ideas.
Yeah,
I
1
think
to
it's
3.
2 to 3, wasn't it?
Oh, 2 to 3. Okay.
I think.
I don't remember necessarily putting this together, but I agree with a lot of them. I remember talking about them, but I guess I'm not on the
Online, I feel that it's not much of interactions and many questions that those providers can ask. And in my own experience, I have got very hard questions that sometimes providers have about where people come from, implicit biases and all of that. So online, I'm not a big fan of online training, but I totally understand where you guys are coming from. Can you guys hear me?
Yes.
Oh, okay. You guys are just so quiet that I was like, oops, what happened?
I know. Yeah, and thank you. That's a good point too, Julissa. And I know that you have that experience of providing cultural validation training. So it's really helpful to hear your perspective of what has worked and what hasn't worked. And
Yeah.
I don't know if there's other suggestions too about, for providers that really can't access. I think the goal probably would get as many as possible, right? To have those in person, but how can we also explore making that online experience a little bit more meaningful and impactful? And I know that.
So I'm not sure if prevention is really addressed here. I think one thing for prevention that is missing here is I don't think all the members understand what their benefits are. And education also. They need to be educated on prevention, not only going to the doctor when they feel sick. They need to go to all the annual appointments and get all the screenings done, all that stuff.
To like improve delivery of
Onboarding of
education
members.
around, yeah.
I'll say, and let me know if you agree, improve onboarding process.
Mhm.
Yes.
Mhm.
And Dana joined us. Dana, we're gonna ask you because we don't remember. Or were these recommendations specific to prevention, or were these overall recommendations for all of the 5 areas that the state is targeting?
Really specifically for prevention. But it's not to say if you have something, overall, because each of the groups are working on specific for, those. So I would say stay with kind of prevention area. If that makes more sense.
Yeah, and like with number 1, all intake forms can be translated into members' primary language. And I think that including language around what aspects of your culture do you want us to take into consideration, and putting it in the intake. I think that it's really important for prevention, that if members have the freedom to say that, you need to take into consideration that I may identify as I'm a male, but I may identify as a female, and that's gonna it's going to impact the types of treatment that the member receives. So I think that preventative work is one, making members sure that they feel comfortable and that they're being heard and that there's a solid relationship because the provider is taking their cultural needs into consideration and their specific needs. And I think that that's a big part of it. In terms of preventative care, you have to build that relationship with the provider. Members need to know that that who they are, what is important to them is important to the provider, so they have buy-in to engage in preventative care. Does that all make sense? I don't know how to quite put that in a simple phrase.
Yeah, no, that's perfect. And I was just going to say, if you can find a simple way to add that to a simple phrase, just to kind of capture all of what you just said, would be great. And I think
Do you think that we could capture it into ensuring that all providers get some sort of training around cultural responsiveness? Because that will encompass not only language, is how, in my mind, this first one is not only talking about language in the sense of Spanish, English, French, is more into the language is understandable for the member, that is not very medical or very technical, and is in a level that the member understands what is being asked and what they need to be doing.
So are you thinking like more trans-created materials?
Yes. Mm-hmm. Well, I'm thinking also on the cultural responsiveness from the provider side, to make sure that if they see members that have a different background, that they respect that they honor whatever background the member has, to make the member feel safe, like to your point that you were saying before, to make members feel safe and confident that the treatment they're receiving is the best. Would be great.
Okay.
I have a couple of recommendations as well, if we're ready to move on to additional ones. So my recommendation would be that HCPF create a recommendation for medical consent, just based on the feedback that I've received and that I've researched regarding a lack of informed consent or just consent in general when it comes to medical processes being undertaken while pregnant and having birth. Also, I would like to see recommendations on alternative birthing practices that can be completed in the hospital, as opposed to just home birth versus hospital birthing practices.
Are we thinking that, just to clarify, make sure I'm getting all your thoughts down correctly, like, is this like a research like policy on how we could encourage, mandate, request that alternative birthing practices be completed in the hospital? You know what I'm saying? Like, how do we move? What would be the ways to sort of make that an action?
I'm sorry, can you repeat that?
Yeah, I'm sure that was a bunch of word soup. Sorry. I guess I'm just trying to think about, like, is this like a research policy to incorporate alternative birthing practices, or I'm trying to make sure that it's like an action thing, just to make sure your thoughts are incorporated.
Well, I know that there isn't really a standardized recommendation, so yeah, I think a research policy would probably be the best start.
But I feel like it does impact things.
So this is Renee. I have a question. In having higher reimbursement rates, I don't think that's the only barrier to providers signing up. I think the amount of paperwork that is necessary. I know a provider where I live in a very rural area, that the paperwork is a nightmare. And so he doesn't want to do it. He's more than willing to do it, even on this reimbursement. I guess my question is, if the reimbursements were higher, how can we guarantee more providers will actually sign up?
Yeah, because the other issue I have heard of is not just like Rian says, it's not only the reimbursement and the paperwork, but it's also the reimbursement speed. Some providers are so small that they need to be reimbursed faster in order to remain compatible and functional, rather than having to wait 90 days to get reimbursed for each service that they are providing.
Yeah, I would say, as the provider, it takes 2 weeks for Medicaid to reimburse me. It takes about 4 months for all the other insurance plans to reimburse me.
But I have heard from some people that it does take 90 days sometimes, and that's a big problem.
Yeah, and I would say definitely behavioral health is a massive issue. Just in general, they don't reimburse very fast, no matter what, if it involves any Medicaid managed care. But yes, I agree with you. I've had issues with, but like Medicaid, surprisingly, once you have to learn to do billing, which is really a responsibility of a practice anyways. But once you learn it, it gets paid in like a matter of 2 weeks. But for all the other plans, not true. I'd say the average.
One be, do we want that to be the improving health literacy, kind of doing like a more broad education for providers, etc.? Do we think that's 3 buckets?
I think that works. And is good.
I think that works as well.
Okay, let me see if I can do some wordsmithing. Get us down to 3, and then I can put it in the chat. Does that sound good?
Sounds good.
Okay.
that members are understanding the materials that they are seeing. And so the intake forms, all of the onboarding forms, you know, that it's and I think that we are doing that. Like the state just had all of the RAIs, complete a language assistance report form, where it talks about materials. How are you delivering materials? How are you making things available? And I think that this all ties into preventative care, that but there is something about the intake forms that I want to keep as one of the final recommendations, that you know, that the state provides intake form, you know, like recommended intake forms that are culturally sensitive. You know, I think that you know, they're trying to sync things up across the state. So it would be nice to have a template, a recommendation that the state would provide a template, recommended template for practices for people to use when working with members.
So do you like what I just put in number 1?
Yeah, I think that that's good. I think that we just want to tie it back to that.
Tie it back. How? Hold on. So I'll be listening. Any suggestions on how to edit this? I think it's tied all together, but let me know if you have any suggestions.
A link to this one, just so I can look at it too, like just read through it.
Yeah,
or is this just a Word document?
This is a Word document.
Oh, okay. Do you want me to just put my email in there?
Sure. Okay. I'm gonna stop sharing for a minute. It's so hard to do that. I apologize.
Right, exactly. That's why I was like, just yeah, and I mean, I like the app. I like that idea of empowering patients, and then the cultural competency. I think few people in this room can definitely know that my feelings about that. But yes, training definitely. But I think it also extends to the main issues that we've had at Health Colorado is actually our frontline staff that are like kind of the first step. So reception, medical assistants, like the people that are also the trusted messengers that maybe don't have the training to be a little bit more respectful of those cultural differences, or just how to present information a little bit more responsible to acknowledge certain triggers, or or at least meet patients where they are,
Is there anyone else who would like this emailed? Jose or anyone? Renee? Oh, we lost Fong.
What email?
I don't have access to my computer right now.
Oh yeah, sorry. Sorry, Renee.
So it won't help. Sorry.
No worries. And we just for our access discussion
into Spanish, which that's important, but there's so much to it. So we're talking about like creating certification for safe spaces, so that providers can be certified in that way, so their actual space is also safe. And then there's the words that we use and the things that we talk about and how we talk about them to people in different communities or people with different learning needs, things like that. How are we vaccinating people? Are we setting up autistic friendly spaces? Are we setting up, you know, places where people can go if their work schedule is different, things like that. So it's easy to get really overwhelmed with it, but I think coming up with options is the most important thing. So saying this person in Routt County has this specific need and their community has these needs. And so finding things that are helpful to get that person on the right track to where they're going is more useful than requiring the same thing across the board. And so I keep coming back to, yes, we can, I love the idea of community health workers and, you know, navigators, things like that. It's super important to be building trust in that way. That needs to be going forward in a lot of our areas. But to be realistic about in some of our rural areas, we're not going to have a community navigator for each priority population in that.
Are we okay with that at least as one?
That sounds good.
I'm just gonna copy this one.
Well, I would include the whole data collection one.
Okay.
Not just 5A.
Or we put the training into the policy advocacy section 2, where it's like the state can kind of take on that larger role of playing that piece of kind of, so we might be able to combine, but we still need 3.
Sure.
Yeah, I mean, the HCPF, like ACC phase 2, like kind of point system had, you know, points to get your PC, like your extra money, like you get that, you know, extra bump, and get to keep it, that you had available appointments. But my understanding, and I haven't looked at actually the ACC phase 3 like document, but there was discussion around they were taking that off as counting as points. So, you know, that there's accountability to transparency around your access to care. I know there's other initiatives that they're trying to clean up, like the information that's available for who's taking new patients, things like that. But I don't know, like just making sure that like there's accountability to continue to always make sure that when they say they're taking Medicaid, it's actually new Medicaid. Because it doesn't matter if they're taking Medicaid. If you're an established patient, you'll know. You know, it's really important to know new Medicaid. And then how quickly are they seeing the patients and how is the process? Because what is the discrimination in that process? Which I can report many, many discriminatory behaviors that are just there to meet the bottom line is they can't have too many because they'll have missed appointments. They'll have, you know, really complex patients that they deserve a lot more time. And so there's only so much, you know, from the complexity of the panel. Usually if you're open to new patients for Medicaid, you're the only one in your entire neighborhood. So you easily can end up closed to new patients within a few weeks. I didn't get the email yet, but I don't know if it's just that I'm not connected.
It's probably because you're external to HCPF. It probably takes on my end a minute to send it to you.
Gotcha.
Yeah.
Yeah, for the sound that doesn't.
So
I like it mandatory.
yeah, so the challenge is just, so so hospitals can choose to um, sort of acquire that designation. But the deal is that people need to know, who's in it and who isn't. So that if you choose not to, just so that, I just think that data needs to be, people need to know.
Maybe then the recommendation is, I know Erin had talked about, creating more publicly facing dashboards and related to health equity. Maybe they can bring that data from CMS website to their website. So we're just trying to point towards it. So if people don't know that exists, that could be a way to amplify like that list. It already exists publicly. It's just more about making sure patients know that that's out there. I will try to add that. I think we have to leave any volunteers to present this information to the larger group. We have 45 seconds to decide. No volunteers. Okay.
I don't mind doing it if no one else wants to.
So
Renee, I have a question about the pharmaceutical. Was that
Yes.
something that we were going to put into the app, or was that something separate?
It is actually separate. It'd be nice to have it linked to the app, but it is a separate thing. But I think it could be linked into the app.
Okay.
Yeah.
Sounds good.
welcome back, everyone. I think everyone's back from the breakout rooms. I popped around to all the rooms and great work was happening. Great ideas were being generated. So it was very encouraging. So I think now what we'll do is we'll have each group share their 1 to 3 recommendations that they came up with that they like to forward to the department. And again, we'll bring these back up again in early 2024 and then actually vote on them, and we'll determine if it's, how many we really want to go forth. It could be 2 from each group, maybe 1 from each group. So we'll work on that determination. But right now we'll open it up and we'll see from each group what their recommendations are that they've kind of settled on. And so I think we'll start with the prevention group.
Okay, this is Clara Cabanis. I can start for the prevention group. So one of the discussions that we have is of the recommendations is to improve the onboarding process for members. And this is to really make sure that members understand their benefits. And to make this understandable for members, it's important to improve how the questions are being asked to members when they enroll in Medicaid, improve also the way that the information is being delivered to members, and to ensure inclusivity and cultural competency, so members feel safe and members feel start trusting the system. And also we talk about the importance of transcreating the intake forms, not only translating them into different languages, but making them understandable in a way that is for language and a very understandable language, and being cultural sensitive for members with different backgrounds. So we also had a discussion around, we know that it's not only a fact of educating members, social determinants of health could be a big barrier for members to access services. So we have a little bit of a discussion of how that could be improved or what type of recommendation we can offer. We didn't have enough time to talk about that, but I just want the group to acknowledge we understand this not only educating members, the reason members are not accessing preventive services. The second recommendation that we came up with is ensuring that providers and community organizations that are in working with Medicaid members, that they receive training or information on cultural responsiveness to help members feel safe and trust the system. And this is something that is very important because sometimes even if the member accesses the services available, if they don't feel safe and if they don't trust the system, they will not go back to continue with their care or preventive care. So those were the two recommendations we came up with.
Thank you. Did anybody have any questions for the prevention group on their recommendations? Okay. Next, we'll move to maternity. You want to share your recommendations?
Great. So our first recommendation, I'm Sheila Davis. Our first recommendation is that HCPF collect qualitative research on the doula experience, as well as collect promising practices on around integrated care teams that include doulas, because we really don't know, what's in the secret sauce for integrated care teams that include doulas and behavioral health providers and obstetricians and nurse midwives. So we really need to collect that kind of data. We also recommend, this is under the data collection sort of heading, that HCPF prioritize research on rural maternal health, because we know that there are disparities for birthing people living in rural and frontier communities, and we really need to understand more about that. And then also under data collection, we want to make a recommendation to CDPHE to create separate African American maternal mortality review committees, as well as Indigenous maternal mortality review committees, because it's very important that the voices of those most impacted need to be elevated, and they need to participate in this, in developing solutions around factors contributing to pregnancy-related complications and death. So that's all under data collection. We also are recommending that HCPF investigate and recommend alternative birthing practices that can be completed in the hospital that lead to better health outcomes. And then our third recommendation is for HCPF to build on the Behavioral Health Administration workforce model. Use that model to create a perinatal workforce model that includes doulas and midwives.
Thank you. Did anyone have any question? Oh, Aaron has his hand raised. Go ahead, Aaron.
I do. Thank you, Dr. Davis. Just a quick question on your third recommendation on birth choice. For your recommendation, can you all clarify if you are asking for birth centers outside of the hospital setting?
So, yeah, we had a conversation about that. And we need to understand, not only do we need to understand, under what conditions are birthing centers sort of the best option, but we also need to understand, within a hospital system, if a birthing person chooses to deliver in a hospital, what are some of the alternative practices that lead to better health outcomes if a birthing person chooses to deliver in a hospital? But we need more birthing centers across Colorado. Absolutely.
Totally agree. I would just have your group consider adding language around fully informed birthing choice as part of it. But absolutely, I'm on the same page. Thank you for that.
The other thing I wanted to add was the birthing friendly designation. This is something that hospitals can elect to participate in. It would be nice to know that, you know, for birthing people, which hospitals have received that designation. So if HCPF could put that on the dashboard, that would be awesome.
Are there any other questions or comments for the maternity group on their recommendations? Okay, we'll move on now to hear from the vaccinations, the COVID-19 group.
I can go ahead and speak to that. This is Sophia with CCHA. So one of the things that we talked about is considering expanding cultural validation training for providers. And we talked a lot about, you know, the difference between making it a requirement versus incentivizing, and just making sure that we're being inclusive of all of our providers, and being realistic about, especially our rural providers that might be the only provider in their community. And if we're putting all of these additional expectations and requirements on them, just being cognizant of how it's delivered. And so, you know, we talked a little bit about making sure that the training is, there's different opportunities for training. So, you know, certainly I think a recommendation would be an in-person training where there's the opportunity to have more dialogue, but recognizing that that might not be realistic for some providers. So potentially just having maybe a menu of options and having some online training be available for that. And when we talked about the difference between, you know, requiring versus incentivizing, we talked a little bit about how, you know, you can't really change the hearts of people. So making it a requirement may not work, but really looking at how we can incentivize and just start to have those more open dialogues and conversations. And then just being inclusive of different aspects. So making sure that we're including language justice, language accessibility, LGBTQIA+, et cetera. And then we also talked about kind of the importance of also accountability. And so rather than it being a one and done type of training situation, potentially how can we have the facilitator of the cultural validation training go back to the practice several months later and talk about what's working, what's been implemented, and areas of improvement, just to make sure that that dialogue is ongoing. The other recommendation that we talked about is exploring sustainable funding for community health workers, such as ambassadors, promotoras, cultural brokers, et cetera, to be able to be paid for their work, potentially through Medicaid billing. We talked a lot about rural communities as well, and really the importance of building that trust between our Medicaid members and providers, and how crucial that is, especially when there is only one provider in those communities. And it could be pretty detrimental if that trust is broken. And so, you know, how can we continue to facilitate those relationships? And then the third piece that we talked about was just around overall access. And so there, I think, have been a lot of creative ideas around, especially in some of our smaller communities, where can we have other providers be the ones to offer the vaccine? So could a dentist, for example, offer the vaccine, or pharmacists, et cetera? And so really leveraging what is already out there and when individuals are already going in for a dental visit, for example, can we also leverage that experience and that time for them to be able to get a vaccine? And, you know, I think in our rural areas too, when transportation becomes a huge issue, just, I think the more that we can get things done in one visit, all the better. I think that covers all of it, but if there's anyone in my group that wants to add to anything that I said, please feel free.
Thank you for that. Is there any questions for the vaccinations group on the recommendations or any comments? Okay, we'll move next to behavioral health.
I can jump in with our recommendations. So for ours, we actually ended up combining a few of our recommendations. We noticed a couple of themes. So the first one is to expand pathways, meaning we want to expand pathways for people with lived experiences and or language abilities to join the workforce. Also expanding pathways to culturally appropriate formats for therapeutic services and supports. For example, not all people benefit from one-to-one therapy settings. Number 2 was improve compensation. So increase compensation for people with lived experiences and or language abilities, recognizing the expertise that they bring, and that we also included compensating appropriately for interpretation services. Number 3, improve health literacy education to providers. To improve health literacy, consider a broad, coordinated campaign with providers, hospitals, local public health, and the state that uses consistent messaging about stigma and what is available to Coloradans in the behavioral health sphere. Increasing the ability to provide a lighter level of care coordination to more people. Essentially the idea being that we want more people to be able to get help navigating the system before they have acute needs, and provide training and information on behavioral health more broadly so people know what to expect when encountering the system, and can provide feedback on making those interactions less traumatizing or isolating.
Thank you for that. I appreciate it. Are there any questions for the behavioral health group and their recommendations? Okay, so now we'll end it up with access to care group.
So we also had quite a few recommendations. It was hard for us to narrow them down. I think what I'm hearing from all the other groups is I think a lot of our recommendations kind of overlap with others. So that's always good to hear. So a couple of our, and I also am with you, we combined some, and I think they seem robust, but like I said, I think there's a lot of crossover between the groups. And one of our recommendations, so access to care, one of our recommendations was to have the state create an app similar to an app you all may have heard about called Be My Eyes, where members could open the app, have access to interpretation in their own language, have access to health resources, including appointments, referrals, and other like health related social needs resources. They could renew their Health First application, review benefits, connect to coordination services, and more. So similar to PCAP, I think this would just be more robust and have additional services included on that app and enhance that. So it'd be like a one-stop shop for all of these things, accessible via login, iPhone, etc. Another recommendation we had was for an assistive and accessible pharmaceuticals. So that was providing members with accessible formats for prescriptions to include mail order, electronic technology to access medications, directions for medications, all other information for medication. And again, if this is sort of it's a separate recommendation, but could also very easily be connected to that same app, and available statewide, to help with those things. And then a third recommendation that's a little bit more robust, I think, with our thoughts are just some policy changes that HCPF can partake in. And we also had culturally responsive care, which I've heard a couple times, I think, in this. And that was training. How can we provide training, providing care in language other than English, having those services available widely. So I'm reading through my notes. Again, the incentive program, we had that listed as well. Have very specific like DEI training for all clinics and providers. And we also really were interested in like having training that was statewide, state focused. And so in theory, any member could walk into any clinic and expect to kind of receive the same style of care, that there's sort of like this training hub out of the department that everyone, whether that's required or incentivized to take, one of those things that just is keeping it consistent, and not only having consistent training, but really putting it on the department to ensure that that training included people with lived experience and people in those different communities that we're trying to reach, rural and frontier especially. And so wanting that member focus as well. And then also increased reimbursement rates for Medicaid, of course, always comes up as a policy change, as well as including services that can be reimbursed or paid for by Medicaid that do include other services like translation services in those clinics that specifically in rural and frontier areas that are really just trying to get by with what they have. And so then they don't take members of their community because Medicaid reimburses at a low rate, et cetera. So how can we make those clinics robust and continue to increase access? And also was discussed in that same vein of just how can we make taking Medicaid and applying to be a Medicaid provider easier and quicker. So how can we incentivize and help those clinics continue to see their community members? So that was a lot. And if anyone in my group would like to jump in, please do. But those are our thoughts so far.
Thank you. And any questions for the Access to Care group on their recommendations? I just want to thank everyone and all the work that has been done and all the recommendations that have come out. They've been great. I think like Lauren mentioned, there were some overlaps. So you guys are all kind of on the same page, the same wavelength in some of these thoughts. But I just want to let you know, I appreciate all your work that you've put into this. So I don't know if there's any other comments anyone has on the recommendation that we've heard. Anything you want to add, Aaron, from what you've heard from the recommendations that stand out to you?
No, I think they're all great. And to Dana's point, really want to humbly thank you all for spending almost 12, 13, most likely 15 months on this task force when we first started this back in July of 2022, where it was accountability arm of our health equity plan as a department. And what started off as an idea has really transformed, and all of the work that you all have done has been, very great. Thank you to our co-chairs, from each of the RAIs and our members and the advocates in the community and the business folks, the consultants, the diverse voices that are part of this task force will not fall on deaf ears. So it's definitely going to be part of how we move forward. I would say as far as next steps, I'll ask Dana and the co-chairs to formally put all of your recommendations into a document we will definitely make sure that it is formally submitted to myself and our leadership. So our Executive Director, Kim Bimsteffer, our Chief Medical Officer, Dr. Peter Walsh, and a few other leaders at the department. And I can tell you that we will definitely have a written response to your recommendations. I can also state that many of the ideas and concepts that you all have lifted up are in some form and fashion already in the works. But this will be part of a formal response. We will definitely make sure that we add your letter and our response in our second version of our health equity plan. We will also be highlighting our raised health equity plans in our second report, most likely sometime after June of 2024. And then part of that, I'll ask Dana and Fawn and so many other people to put your names attached to your recommendation so you are formally recognized for the work that you have done and the contributions. But yeah, so far, I'm just very thankful for you all showing up every quarter with great information. So yeah, I actually look forward to seeing it all written down in one document. We'll definitely make sure that we let you all know what next steps look like. I see Jose's name. Go ahead.
Hi. Thank you, Aaron. And I kind of want to make an announcement. It's not related to what you were saying, since you were kind of closing statements. Before we close, I wanted to make something public, and it's going to come out later this week or next week as an official statement from CCDC. I had to, as of 2 weeks ago, I was forced to resign to the Rocky Mountain Human Services Board because the Department of Healthcare Policy and Financing and the Developmental Pathways provider was suddenly accusing me and Julie of siding with RMHS and violating the anti-solicitation clause because we advocated for choice in the case management redesign, and we are stating that there are many board members for many CMAs and CCD former CCDs who are outspoken advocates, and the difference is that they're either white appearing or non-disabled people who have never been forced or accused of siding because they advocate. Most board members for any organization of this type will have other roles that are somewhat related, and it is aggravating, it is insulting that only now that a person with a disability who is a BIPOC community member is being retaliated against. So in order to protect RMHS and CCDC and myself, because I am also a client of RMHS, I had to resign as the board member and board chair. I find it insulting that DP is holding our HIPAA hostage only because an outspoken member of the community is a board member. When in every meeting where I was participating, I always announced very clearly when I was speaking as a CCDC advocate or as a board chair of the RMHS board. They are, with this, they are forcing 1,600 clients to remake their choice between DP and RMHS. They were blocked off the RMHS board, the RMHS database, so that they had to choose again. And they will not received news, as far as we know. They have not received news that they were taken automatically off of our MHS, even after they have chosen that into developmental pathways.
Well, Jose, I'm sorry that that's taking place, and I can probably speak for everyone on here that you are a giant as an activist and advocate for all that you do. So I just wanted to thank you for all that you have done and will continue to do. I'm not really privy to what you just disclosed, so we'll definitely note that. But know that all that you've done for this task force specifically will really help continue to elevate how we meet the needs of folks who are disabled in Colorado. So just want to give you your flowers and all of you all who are on this call, because this is how we disrupt systems, right? Where we can really understand that when we come together collectively, that we have the audacity to do things differently and to name things and to hold systems and people accountable. So I just want to, speak for myself that I thank you for what you do. I'm gonna turn it back over to Dana.
Thanks, Aaron. And yes, I just want to echo everything Aaron said. Jose, we're thankful that you're here with us and all the work that you have done, and all the work that you will continue to do. So we appreciate you. Just real quick, I want to recap and then we'll open it up to any open items or sharing that anyone has. Between January and February of next year, we will come back together. We will put all the recommendations from each group together. And then as a large group, we will decide which recommendations, and it could be all of them are forwarded to the department, or if we combine some, since there are some that kind of overlap and have similar themes. So we'll work through that process early 2024 and do the official recommendation to the department. And we'll get that written up. So be on the lookout for a meeting, probably late January, early to mid-February, for that meeting to take place. And then with that, I'm just going to open it up to see if anyone has any thing they would like to share as we're kind of wrapping up for today's meeting. So if you have any comments or any anything that you would like to share with the group, feel free to do so now.
Dan, I have a quick question.
Yes.
So our group, the Access to Care, we pulled our recommendations off of Google, since it's not accessible, so we had it in a Word document. And I was curious when you wanted those recommendations back, just because we weren't able to work on it collaboratively during the breakout. I wanted to give my group another chance to kind of review before we submit. So I didn't know if there was a deadline on your end of when you wanted our recommendations.
Let's say if you can get it no later than, I'm trying to look at my calendar. Let's say no later than December 15th.
Okay. Perfect.
Just make sure you can send it to me or put it back in the Google Drive, whichever is easier for you. Okay. If you can send it to me, and then I can upload it, and then I'll just work on combining everything.
Thanks, Dan. I appreciate it.
And that goes for all the other groups. If you're working offline with each other and you want to just tweak them or maybe add some things, let's just say December 15th, everything should be kind of in its final state as far as your recommendations from each group. And then I will kind of combine and do a full write-up of each of the recommendations for our January or February meeting for us to go through at that point. Yes, Sheila?
So will you send out a draft of the recommendations? So if we want to do some wordsmithing, we can, or do you have another is there another process that you would prefer?
No, I can send out the draft of the recommendations. And then you can kind of wordsmith, tweak, or, as a group, you may want to add, some additional wording. We can do that. So I'll do that probably within the next week. I'll just kind of send them out again for you guys all to look through one last time and give you through December 15th to kind of finalize everything at that point. Any other questions or anything anyone wants to share with the group? Renee, were you speaking?
Can you hear me?
Now I can.
Okay, I was trying to make sure I was unmuted. I just had a situation that was brought to my attention yesterday by a member that happens to have many disabilities, very complex, and she is also blind. And she asked, and I don't even know where we would recommend this, but I'm bringing it here because it is, I think, a health equity type of thing. But she has difficulty determining when she gets her Medicaid card, which card it is. And is there a way that when they do make these Medicaid cards, that they have some kind of a tactile something, even if it's just like a line, a raised line or something that could easily be, oh, this is my Medicaid card, instead of going through and going, is this it? Is this it? Is this it? And somebody be dishonest and tell them something else and end up giving them a credit card or something. I don't know. But where do you even go to whom is actually making these cards to try and make this suggestion to help someone who has a visual impairment and is unable to see that card?
That's a good question, and I'm gonna kind of defer to Aaron to see if he knows which area kind of works with our Medicaid card.
Yeah.
Can you
I'm not sure
send
who
that-
actually
that email, and I can forward it to our internal comms team, and they can work with our eligibility folks just to make sure that we can get that rectified.
Yep, sure. I will do that.
Yep, but that was a good idea to have some sort of raised. some
Even if it was like
indication
the
what
seal
card
of,
it is.
you know, whatever, something.
No, that's a good idea.
Okay, thank you.
Erin, would you mind forwarding that information also on to our people with disabilities and mental illness group? I think that that's a thing I'd love to follow up on and have some conversations around with folks in the department who are focused on those kind of things.
Yeah, for sure.
Thanks.
Anything else from anyone?
Yeah, Dana, this is Fawn.
Yeah, Fawn.
Oh, I'm actually on my phone because my internet was unstable earlier, but one place. Well, given that this is our last Health Equity Task Force meeting of the year, I'd like to thank you and Aaron for really organizing and facilitating throughout the whole year, and to get us to this point where we're able to come up with really excellent recommendations to advance health equity. So a thank you to your team.
Oh, thank you. And I would, want to thank you and Essie and Diane and everybody of the co-chairs in facilitating these meetings. Couldn't have done it without you guys, so I appreciate it.
Yeah, great teamwork. Thank you.
And did I see a hand somewhere or no? Maybe not.
We were just clapping.
Oh, that's where I saw. Okay, thank Jose. Thanks for the class. Well, if there's not any other comments or questions, I'm gonna give back everybody about 20 minutes of time. Wish everyone happy holidays. And we will see you all again next year. And I will be getting information out on the draft of the recommendations. And then we'll see you guys in early 2024 so we can kind of finalize this process up. So have a wonderful day and the rest of your week. And we'll talk to you soon.
Thanks so much. Bye-bye.
Thank
Bye.
you.